Platelets are small, discoid-shaped anucleated cells, typically 2 to 4 micrometers in diameter. They are the second most numerous cell in the blood, with a normal range of 150 to 450 times 10 to the 9 per liter. Platelets are produced in the bone marrow from megakaryocytes, which originate from megakaryoplasts. Nearly 30% of platelets are retained in the spleen. If the spleen is removed, the platelet count typically increases by about 25 to 30%. Platelet disorders can be categorized into quantitative disorders, which affect the number of platelets, and qualitative disorders, which affect their function. Quantitative disorders include thrombocytosis and thrombocytopenia. Thrombocytopenia is a numerical reduction in the number of platelets in the peripheral blood. A platelet count below 100 by 10 to the power of 3 per microliter is conventionally viewed as clinically significant. Mechanisms of thrombocytopenia include hypoproliferation of megakaryocytes, increased consumption of platelets in the peripheral blood, hypersplenism, or any combination of these factors. Hypoproliferative thrombocytopenia is usually part of marrow hypoplasia. Common causes include aplastic anemia, megaloblastic anemias, subleukemic acute leukemia, and myelodysplasias. Increased peripheral consumption of platelets is divided into immunological and non-immunological disorders. These conditions lead to increased destruction of platelets in the peripheral blood. Causes of immunological consumption include systemic lupus erythematosus, chronic lymphocytic leukemia, ITP, and other viral illnesses like HIV/AIDS and malaria. Non-immunological consumption causes include thrombotic thrombocytopenic purpura, disseminated intravascular coagulation, massive transfusion with stored blood, and hemolytic uremic syndrome. Hypersplenism or splenic sequestration is another mechanism of thrombocytopenia. Splenic sequestration is directly proportional to the size and vascularity of the spleen. The clinical manifestation of thrombocytopenia is bleeding, dictated by the site, amount, and rate of the hemorrhage. Severity ranges from cosmetic concerns like skin bleeding to fatal brain hemorrhages. Laboratory findings for platelet disorders include clinical examination and history, bone marrow examination, and immunological tests to detect antiplatelet antibodies against antigens like GPIIB/IA and GPIB. Thrombocytosis is any increase in platelet count beyond the upper limit of normal. Counts above 600 by 10 to the power of 3 per microliter are considered significantly increased and may be seen in various disorders. Causes of thrombocytosis are varied, and specific diagnoses depend on the platelet count and associated morphological changes. A platelet count over 800 by 10 to the power of 3 per microliter, with morphological changes and mild polymorphonuclear leukocytosis, is almost diagnostic of essential thrombocythemia. Splenectomy is also associated with thrombocytosis. Iron deficiency anemia can cause mild thrombocytosis with small platelets. Systemic malignancy is the most common cause of reactive thrombocytosis, accounting for about 30% of cases. Hemorrhage is also a potent stimulus for thrombopoiesis. Bernard-Soulier syndrome is a rare autosomal recessive qualitative platelet disorder. It is characterized by prolonged bleeding time, thrombocytopenia, and large platelets due to a defect in the platelet glycoprotein IB9X5 complex. The defect in Bernard-Soulier syndrome leads to failure of platelet attachment to von Willebrand factor and exposed collagen. Symptoms include purpura, epistaxis, and gingival bleeds. Laboratory findings include prolonged bleeding time and large platelets. Glanzmann's thrombasthenia is another rare autosomal recessive qualitative disorder. It is characterized by an absent or deficient membrane glycoprotein IIB-IIA complex, prolonged bleeding time, and a normal platelet count. This defect prevents platelet aggregation. Bleeding manifestations in Glanzmann's thrombasthenia range from minor bruising to fatal hemorrhages. Key laboratory findings include normal platelet count, prolonged bleeding time, absent platelet aggregation, and absent clot retraction.